So today we're going to talk about the cardiac patient care and assessment. So cardiovascular disease includes disease of the heart and blood vessels. Most heart disease does develop over time, and this occurs when the arteries develop atherosclerosis, which is a plaque buildup in the arteries. So this process does begin in childhood, and gradually you develop a buildup of plaque inside the arteries. Plaque contains fat, cholesterol, and other substances, and when it does grow large enough, it can reduce blood flow to the heart. So when plaque blocks the artery that feeds the heart, it can cause a heart attack. So up here in the corner is just a picture of a normal coronary artery. So you can see the arrow indicating proper blood flow. And then here's a cross section of the arterial lumen, which shows it wide open. And then this picture, the yellow stuff here is the plaque, the cholesterol buildup. And you can see this arrow, how there is obstruction of blood flow. And then in the cross section here, you can see it's about 60 to 70% blocked. So risk factors for heart disease is history of coronary artery disease. So if a patient had previous heart attack, if they had an angioplasty or a stent placed previous, they're at a higher risk. Smoking, hyperlipidemia, which is high cholesterol. Diabetic patients are at a higher risk. Stress, and I always tell my students that stress is, usually a little further down the list, but I always say that it should be number one on the list. Obesity is more than 30% over ideal body weight. Depression, family history, so genetics, of course, plays a big role in heart disease. The type A here with hostility factor, we always joke about this too in class. That's like somebody who has the type of personality. Some examples is road rage. I always give the example of when you're waiting in line at the grocery store and it's 10 items or less, and you have 2 items and the person in front of you has 15 and you're counting them and you're getting more and more angry. So that's what type A personality with hostility factor is. Hypertension, of course, is also a risk factor. Physical activity, if you don't get at least 30 minutes of physical activity most days of the week, that's what the American Heart Association recommends. Age plays a factor. Race, high-fat diet, that goes hand in hand with high cholesterol and physical activity. Homocysteine levels and birth control. Now, homocysteine levels is similar to high cholesterol. It is usually genetic. So if someone in your family has high levels of homocysteine in their blood, you may develop that as well. Homocysteine is an amino acid, so they do find how high the level is by doing lab work. And I think they found this about 5 years ago, that they were saying that it was a high indicator of heart disease. And then some articles came out that said that it wasn't really an indicator of heart disease. And now it's kind of coming back again that they are saying that it is in fact an indicator for heart disease. So again, homocysteine levels, it is usually genetic. It's an amino acid found in the blood, and they do a lab test to find that. And it's kind of, like I said, it's kind of like having high cholesterol. Birth control, that plays a factor really in patients that are over the age of 35, and they've been on birth control for a long period of time, and they smoke as well. That's when you have that higher incidence of developing a blood clot. So then we have the risk factors divided into 2 columns here, modifiable and unmodifiable. So the modifiable risk factors are the ones that we can somewhat control with diet and exercise. So high blood pressure, high cholesterol, smoking, diet, the physical inactivity, obesity, alcohol use, stress, depression, the homocysteine levels, the birth control, and diabetics. Those are modifiable. The unmodifiable are ones that we can't change. So heredity, genetics, your age, your race, your gender, and if you had a previous stroke or heart attack. So risk factors you control is if you have high blood pressure, that increases your risk of heart disease and stroke. Smoking, you have a 2 to 4 times greater incidence of developing coronary heart disease than non-smokers. High cholesterol equals higher risk of coronary heart disease. Physical inactivity increases your risk. Obesity or overweight, so excess body fat, especially around the waist. We say if someone is apple-shaped, that they really have a lot of adipose tissue in their abdominal area. That increases the likelihood of developing coronary heart disease. And then diabetics are at an increased risk of heart disease. So more risk factors here. Total cholesterol, they like to see less than 200. LDL, which we call the bad cholesterol, less than 100 to 160. The HDL cholesterol is the good cholesterol, so that they like to see 50 or higher. Triglycerides less than 150. Blood pressure, the new American Heart Association guidelines about 5 years ago, I think they came out with this, that blood pressure should be less than 120 over 80. And then fasting glucose should be less than 100. So the factors here, the body mass index, the waist circumference, and then exercise. And the body mass index is BMI, and that should be less than 25. And then waist circumference should be less than 35 inches for women and less than 40 inches for men. So they do say, new research has said and indicated that waist circumference is a better predictor to look at for physicians than the BMI, because the BMI, the body mass index, does not take muscle mass into account. So someone who is real physically fit, is real muscular, their BMI might be greater than 25 when in fact they're not obese. So I think more and more physicians are looking at the waist circumference versus the BMI. And then exercise, like I said before, should be a minimum of 30 minutes most days, if not all days of the week. So the Simple 7 heart health factors, this was taken from the American Heart Association. They just developed this Simple 7. So get active 30 minutes every day, control cholesterol less than 200, eat healthy, heart healthy foods, manage blood pressure less than 120 over 80, lose weight, and then the BMI versus the waist circumference, reduce blood sugar less than 100, and of course the last one, stop smoking. So cardiac assessment, when we assess these patients, we look at chest discomfort issues. So we look at the occurrence, the location, the duration, the characteristics, if there's any other symptoms, if they have any radiation, treatment, and then their rate of discomfort. So we look at the acronym OLD CART, and O stands for occurrence, so when it started, if the patient is having it now with or without activity. L is location, where is the discomfort located. D is duration, so when did it start? How long has it lasted? Does it come and go, or is it a constant discomfort? C is characteristics. A is accompanying symptoms, so shortness of breath. Are they diaphoretic? Diaphoresis means profuse sweating. Dizziness, radiation to the arms, neck, or jaw. And then R is relieving factors. So what helps resolve or alleviate the symptoms? Rest or deep breathing? Did they take any medication? Did they change position? And then T is for treatment. So what helps alleviate the symptoms? Rest, deep breathing, oxygen, nitro, change in position, or morphine. So that's similar to the relieving factors. And then we also have a different acronym, PQRSTU. And the PQRSTU just follows the waveforms on the EKG. I guess that's why they developed this one with the P wave, the QRS complex, and the T wave. So P is precipitating or palliative. So what precipitates the symptoms? Does anything make the symptoms worse? Stress, anger, exercise. What makes the symptoms lessen or go away? Q is for quality or quantity. So what does the symptom feel like? Are you having the symptoms right now? Is it better or worse than you've experienced in the past? And to what degree does the symptom affect your life? R is for radiation or region. So where in the body does the symptom occur? Does it radiate? Does the pain radiate down your arm? Does it radiate to your jaw? And does it move between regions? S is for severity, so how severe are the symptoms? We ask our patients on a scale from 0 to 10. 0 is no pain, 10 is the worst pain ever, and they rate your pain or rate the pain. And I always tell the students, this is very subjective because everyone's tolerance for pain is different. So, if your patient is saying that they're having chest pain, then they are, and you need to listen to your patient and realize that everyone's tolerance is different. T is timing or sequence. So when did the symptoms begin? Was it sudden or gradual onset? How often do they occur? And how long do the symptoms last? And then U is understanding. What do you think caused the symptoms? How do you feel about the symptoms? Are there fears with it? And how has the symptoms affected your life? And then the last one is, what are your expectations of the healthcare team? So these are all just 2 acronyms, the old CART and the PQRSTU, just something to think about and remember when you're asking questions to your patient regarding their symptoms and their chest discomfort. Other cardiac assessment pieces are heart rate and rhythm. So we would check the patient's pulse, check their EKG, their heart sounds, their skin color, their temperature, if they have any swelling, and their blood pressure. So collaboration with the MD. If this is an emergency room patient, when they do come into the emergency room, the first thing we do is give the patient oxygen, ask them if they took aspirin. If they did not take aspirin at home, they would be given aspirin. Nitroglycerin can be given as well. And the good rule of thumb here for nitroglycerin is 1 nitro every 5 minutes for 15 minutes for a total of 3. So, and the only patients that are going to have nitroglycerin on hand are patients that had a previous episode of chest pain or MI. So they would have nitroglycerin on hand at home, and those would be the patients that would be instructed to, if they have an event, to take 1 nitro every 5 minutes up until 15 minutes. If they don't get relief after 3 nitroglycerin, then we tell them to call 911. Because remember, you never want to drive yourself to the emergency room, and you never want a family member to drive you to the emergency room. Heparin and thrombolytic agent. So heparin is a blood thinner. It doesn't break down clots, but it does thin the blood. And thrombolytic agents are clot busters. And there is a chart that we look at to see if the patients are candidates for that. The other thing that we do in the emergency room, or when the patient's an inpatient, cardiac enzymes. These are blood tests that are done. Troponin, CK, and MB, and the troponin is the most popular cardiac enzyme done. And what happens with these is they do these lab tests because if someone is in fact having a heart attack, or if they're having ischemia, that lack of blood supply to the heart, the troponin will be elevated. So it will be greater than 0.1. And then we evaluate the patient. Do they need a stress test? Do they need to go right to the cath lab? And then once they do have a stress test, or they go to the cath lab and we see, what we found during any of those procedures, do they need a stent? Do they need medical therapy? Or do they need CABG, which is coronary artery bypass graft, which is open heart surgery? The next 2 slides we talk about angina. We talk about stable angina and unstable angina, and you do need to know the difference between these two for your exam. So stable angina is squeezing, a heaviness, crushing type pain in your chest. A lot of patients say it's a pressure type feeling, a burning feeling, a strangulation feeling in their chest and neck. It radiates to their neck, arm, shoulder, or jaw. Some patients do say it's a mild, vague discomfort, that it's not really pain, but it's more perceived as an ache. The location of pain may differ. Pain's usually felt beneath the breastbone. In addition to chest pain, there may be associated pain that radiates to the arms, shoulders, neck, jaw, or back. And the patient may look pale. They may look diaphoretic, that's profuse sweating, and they may be short of breath. Blood pressure and heart rate may be higher than normal. because a lot of these patients do develop anxiety when they start to have that discomfort feeling in their chest. They might have an abnormal heart rhythm. Their EKG might look abnormal, but that's not always the case. And then if the sensation includes sharp shooting knife-like pain, it's probably not angina, and that's usually muscle related. So this next slide is unstable angina, and this is unpredictable. So with these patients, this type of angina comes on at rest or during sleep, so it might wake them up in the middle of the night. Not often or always relieved by nitroglycerin. Symptoms are more intense, they last longer, and radiate to different areas than if the patient had an episode previously. They have something to compare it to. But if this was the first time that this was happening to the patient, then they wouldn't have anything to compare it to. So they are instructed that if the pain lasts longer than previous attacks, and if it feels different than previous attacks, that they should call 911 right away. And again, unstable angina can be less responsive to medication. So just a picture here. Symptoms of angina can spread anywhere between the belly button and the jaw, including to the shoulder, arm, elbow, and hand, and it is usually on the left side. And then just another picture here when there's insufficient blood flow to the heart. You see this yellow plaque build up, and you can see how it decreases the size of the arterial lumen and how blood flow is going to be obstructed in that vessel. And again, sharp stabbing chest pain that increases with inspiration or changes with intensity with body position is typically muscle related or pleuritic chest pain. So myocardial infarction, when someone is having an MI, that's when they have prolonged interruption of myocardial perfusion. So there's actual cell death. So they get that crushing, squeezing pain, they're pale, they're short of breath, and they have symptoms lasting 30 or more minutes. Some patients say it's the worst pain ever. They have impending doom. They get no relief with nitroglycerin. They get no relief with rest. And then, of course, female patients, diabetic patients, and elderly patients may have vague symptoms. They may have different symptoms. We've had female patients in the past that the only symptom that they had was jaw pain. We had one patient that went to the dentist because she thought she had an infection in one of her teeth, and it actually turned out that she was having an MI, but that was her only symptom. And as far as diabetics go, remember, diabetics, they tend to get the neuropathies, so they don't have the same feeling. So sometimes the diabetic patients, because of those neuropathies, they don't feel the chest pain. So those are the patients that we say have a silent MI because they don't feel the chest pain. So acute myocardial infarction is abbreviated AMI, and it is the rapid development of myocardial necrosis caused by an imbalance between oxygen and demand. So this usually results from plaque buildup. The plaque can rupture, and then a clot forms in the coronary vessel, and that results in blockage of the vessel and reduces blood supply to a portion of the heart. So here's just a picture again of plaque that is blocking the artery, and then you can see here a clot has formed and has obstructed blood flow to the heart. And this is the right coronary artery, and the right coronary artery feeds the inferior part of the myocardium. So we would see changes on the EKG in those appropriate leads, but we would, because of looking at the EKG, we know that if there are EKG changes in certain leads, it rings a bell that it's probably going to be the RCA, the right coronary artery. So that's how you correlate everything, and that's how by the end of this semester everything should come together, and you should be able to look at an EKG, see the EKG changes in certain leads, and be able to tell which artery is blocked. So then this picture here just shows the initial zone of ischemia. So when they do have a blockage in the artery, they get that ischemic area due to that lack of blood supply. And if we don't get that patient to the cath lab quick enough and get that artery opened, then the muscle starts to get injured. So that's what this second layer is. So once that muscle starts to get injured, again, time is of the essence to get the coronary artery open. So if they do not make it to the cath lab at that point, then you get this zone of infarction. So this is when the muscle actually infarcts and dies. And once that part of the muscle is dead, we can't restore blood flow to that part of the heart. So again, myocardial infarction, chest pain, usually across the anterior precordium, tightness, pressure, or squeezing. It might radiate to the jaw, neck, or arms, back, or epigastric area. And the left arm is affected more frequently than the right arm. Patient might be short of breath, which may accompany chest pain or occur as an isolated complaint. Nausea and or abdominal pain, anxiety, lightheadedness, and syncope, which is passing out. And some patients might have a cough. So some do's and don'ts. And I did say if a patient's having pain, then they are having pain. Listen to your patient and remember that it is subjective, that everyone's tolerance is different. Don't reveal test results. We are instructed as technologists to tell the patient that the doctor has to look at everything and then they will get back to them with the results. And then don't get caught up in conversation. It is easy, if you work in this field every day, that it doesn't seem like it's a big deal to you and you talk about your weekend events. But remember that the patient, it might be their first time in the cath lab or having an echo or having a stress test, and they are very nervous and they have anxiety about it. So your first priority is the patient and making sure that they're comfortable. Always ask for allergies. Always check the name band, and we always ask the patient to repeat back their name and date of birth, and always ask for a med sheet. So hopefully when your patient comes to your department, they should have a medication sheet with them. If you need to leave the patient, you can just walk outside the room, prop the door open, and then they can, yell for you. On the floors, they typically have a call bell that they can, push the button if they need assistance. And then remember, the patient's scared, and it is a different environment for them. So just, make sure, again, to make your patient your priority and to make them comfortable at all times. If you do get a patient that has an IV pump, just when they come to your department, just keep it plugged in. If it beeps and you're not sure why, just find someone who can help you. Do not change settings, obviously, on the pump without a doctor order, and don't reset the pump yourself. And then communication, just have good professional communication with the nurses, with management, with your colleagues that you're working with. And as a student, make sure you have good communication with your preceptor and everyone that you're working with. When you do need to send a patient back to the floor, just make sure that you call. We usually give a small report to the nurse so they know what happened during the procedure. And then some nice to know tips. Shifts that they work 7 to 3, 3 to 11, 11 to 7. These are the typical shifts, but remember that there are 10-hour shifts, 12-hour shifts. But, just know that there might be a delay if you try to send a patient back to the floor at 3 o'clock and it's during change of shift, because the nurses meet with each other and give report to each other about their patients. And remember, just let your nurses know vital signs, medications that were given, and just remember to give them a small report.